Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, I'm Eileen Ruhoy. I am the co-host of Unraveled, Understanding Complex and Chronic Illness. Is that the title of our podcast?
Give or take.
Okay. And this is episode number 4 for our podcast.
And I'm David Kaufman, the other doc in this podcast.
How do you like this hat, by the way?
I do like it.
So I'm trying to wear all the hats that patients have sent me, and this is one of them. So
I've done that. That's so great. That's really nice.
But today's topic is cranial cervical instability and all that comes with it, right? CCI, as it's otherwise known.
Right.
And you and I see quite a bit of it.
Right. So just to remind, we will call it CCI. That's what it means, cranial cervical instability. And it's pretty complicated, incredibly relevant to our patients. So let's
super relevant. I mean, I think that's the most important point. And actually more recently being recognized than I think ever before. And also more recently, more acknowledged as a component of the reasons why a lot of our patients have difficulty with ambulating and are often housebound, if not bedbound,
Right.
and also all the other problems that go along with it, including dysautonomia, headaches, and so on, and changes of intracranial pressure, right?
Right.
So CCI, cranial cervical instability. So we know that there's the occiput, which is, part of the skull, and then there's C, which we refer to as C0, and then there's C1 and C2, the upper levels of the cervical spine. And so that joint that holds the C0 to the C1, C2 complex can become unstable, specifically in people who are hypermobile or have a connective tissue disorder not otherwise specified. And, hypermobility, I always say, is not a disorder, like not a problem. Lots of people are hypermobile. That's why we've got lots of great athletes out there in the world. But when there are symptoms in hypermobility, then you often have to start thinking about maybe there is now instability. So instability of joints. And specifically, this joint is so important because it houses critical anatomy, right?
Right.
Like the lower end of the brainstem, obviously the vessels, that feed the brain, that drain the brain, the CSF compartments. It abuts the posterior fossa, right? So sometimes with connective tissue disorders, we see things like low-lying cerebellar tonsils or even a frank Chiari malformation 1. Right. And so all of that makes a very crowded C0, C1, C2 joint space. And it becomes unstable when the ligaments aren't really holding it close together.
Right. So when I bring this up with patients initially and with other physicians, but I'll do it in terms of patients, I like to explain it a little bit this way. We have this huge, heavy thing on our head, on our shoulders called a brain and a head, a very, very heavy organ sitting on this skimpy little neck. It is the most, or one of the most, I think it is the most mobile joint in the body. You can turn and rotate and flex and extend and everything else. And the only way you can do that is to have ligaments and tendons and things that keep it in place, but they're not so tight that you can't have that mobility. So they are, in fact, more susceptible to injury or damage or what we'll get into later, the effects of inflammation, particularly in a patient who might have a connective tissue disorder. And because the brain is so big, it flows into the brainstem and the occiput, and then that turns into the spinal cord and it passes out through this tiny little hole called the foramen magnum. And the rest is history.
That's right. That's right. Because, while the foramen magnum is the largest hole of the skull, it's still just a hole and it's got very defined, perimeter. So, right. It can only hold so much for sure. And that joint is held together by, almost 20 different ligaments. And so I think nature made it so that it recognized how important this particular joint is, tried to give it a lot of ligaments to hold it in place. But when you have any kind of ligamentous laxity, and then of course, as we know with our patients, the chronic effects of infection, but other environmental exposures, sometimes with recurrent TBIs and whiplash, any kind of physical trauma, that just degrades all of the connective tissue even more, which includes the ligaments. And so things then start to become unstable. And after it's unstable for a period of time, then you can develop instability. And to me, those are different words. I think people use them interchangeably, but to be unstable is one thing. It almost confers that there's this idea that at times it's a little bit more stable. But when there's true instability, that means it's symptomatic and it's basically unstable all the time. That's sort of how I see it. I could be
agree.
completely
No,
wrong
I
with
agree
those
completely.
definitions, but that's sort of how I explain it to patients. And so, being hypermobile isn't a problem. Having CCI is not necessarily a problem, certainly not where it requires surgery tomorrow. But if it's truly symptomatic and progressive and worsening, then, I often explain that it's an anatomical problem, right? So surgery is really, at least at this moment in our medical history, is the only real option to correct the anatomy. But of course, we do a lot of work in trying to reduce the inflammation to make the ligaments a little bit tighter. And I think that that's, what a lot of people appreciate, right? Because not everyone is excited about surgery.
Right. I think the challenge for us as physicians and for patients, of course, is finding and diagnosing those patients before they have instability, before they have CCI. Because yes, there are things we can hopefully do to tighten the ligaments and tighten the connective tissue and strengthen the muscles, et cetera, et cetera. But once they have developed anatomical dysfunction, instability, I'm not sure anything else will fix that. And that's a huge conversation that we have all the time with our patients. I don't know how you would, to put it crudely, how you would lift the head up simply with exercise. Or therapy.
Right, you can't. I mean, you could temporarily, for sure, right? And oftentimes, someone will tell us, like, oh, I feel so much better when someone holds my head up, or during physical therapy, or if they happen to see a chiropractor, or, so they will actually almost give you the clues to CCI. And I think it's interesting that, patients sometimes, the way they describe their symptoms, it'll be in their history. They'll say, my head feels too heavy. I have a hard time holding it up. If I move my head, my neck hurts. Symptoms flare when my head is in a certain position. And some patients actually come in the way they even sit. I notice how straight their head is. Sometimes they have like what we refer to as lateral collis or anterocollis, torticollis. But they just hold their head differently on their neck. And you can almost see it. And sometimes this is weird, but I actually, when they're giving me their history, I'm often looking at the tops of their ears, and if it's sort of a straight line across, sorry, this microphone's in my way. It's if a straight line across, and if it's not, if it sits in any kind of off position, you can almost see it. Now, that doesn't mean they're CCI, of course, because lots of people, I think including myself, by the way, I'm just sometimes more comfortable sitting like this. But if they're obviously here in front of me because they have symptoms, and I'm listening to their symptoms, and I sort of see this asymmetry to the way that they're holding their head, I start to really think about it more and more.
Yeah, I think we're going to get into this more in the next episode,
for sure.
where we're going to discuss how taking a history. But what you're saying is critically important, and that is listening to what the person says and asking some key questions that may sound ridiculous. And I won't give it away. We'll do that in the next episode. But it's really, really important.
Very
Patients
important.
don't come in and say, I think I have CCI. Sometimes they've read a lot and they question
it's all over social media.
Right. But, it's a key part of the history taking.
Yeah, that is an important part that, again, we will address in the next issue. And I think that because patients can be better helped if it's thought of at least earlier on. And, we're not suggesting, obviously, PCPs know what to do about it necessarily, but to acknowledge it and to recognize it and then send them to make the proper referral, I think is important. And we'll get more into that, of course. But I think what's important is that the instability can cause what we know as cervical medullary syndrome. And that really implies basically that there is some level of compression of the lower end of the brainstem. And the lower end of the brainstem has, important nuclei and is sort of also, don't forget there's ascending and descending neural pathways, and that's sort of where they start and end, right? So it can affect really just about any function of the body for the most part. And it doesn't always, in fact, it usually doesn't affect all of the functions, clearly, but it affects many, and it can really make people very disabled. And so it's an important diagnosis in that regard. And of course, the surgery is the fusion, right? C0 to C2 fusion. Sometimes with posterior fossa decompression, if that's indicated. And, as a neurologist, certainly my end game is not that anyone gets a fusion of any part of their spine. So, but yet we do know that that is, at least for now, the most effective means of correcting the CCI.
Right, right. I tend to look at it in as a spectrum, as everything else we do is spectrum kind of disorder, and in groups. So there's patients who may have some, what was the other word you used? Not instability, but
Unstable.
unstable. Thank you. So some unstableness, but are very functional or moderately functional.
Absolutely.
Okay, and they may have POTS, and they may have mast cell activation, and they may have hypermobility EDS, but they also have a job, and they're working and they're functioning. And for those patients, our job is to keep them functioning and keep them better, and do anything possible to reduce inflammation and strengthen connective tissue.
Right.
And that's probably topics for other talks, but it's a key point. The second group are patients who are not so functional, but not bedbound. They can get up and do things. They're often not able to work. They often have more severe POTS, more severe mast cell activation, which is interesting because I'm suggesting what I believe, which is that is related to the brainstem compression, but they're doing sort of okay. And that's the group that may be headed to surgery, but you work even harder to avoid it. And then there's the group which are just profoundly disabled, usually 80, 90, 100% bedbound, certainly homebound. And in my experience, all the drugs in the world, all the titrations, all the medication trials, all the expert, beautiful treatment for their POTS and their mast cell and their small intestine bacterial overgrowth and their autoimmune illnesses, I can fix all that, and they're still bedbound 100%. And that's because I can't fix a compressed brainstem.
Yep, that is absolutely true. And of course, the problem is that once they're in that state, to get them to surgery is a further obstacle.
Challenge.
Right.
Yeah.
So, so we struggle with, do we proceed with surgery earlier on when patients are not bedbound, when they're somewhat functional, even though they're very symptomatic, even though they don't want surgery, but we sort of know just from experience that they have the better chances of one, an easier recovery, a better outcome, a lower chance of relapse, and the travel to the surgeons that do it is a lot easier, of course. Do we do it then or not? Especially when patients are really trying to avoid the surgery and they try all these injection therapies, which I think, there's a lot of good response to them, but they have not yet proven to me that they obviate the need for surgery forevermore. Because, it doesn't correct the underlying connective tissue problem. And so over time, it's, the instability is going to rear its ugly head again. And now you might be in a more, symptomatic, disabled state. And then we're stuck with trying to get you to surgery.
Yeah, it's a huge challenge. I mean, like you, I'm an internist, internal medicine. So I've spent, like most internists, 40 years in my case, doing anything possible to have patients avoid surgery. That's kind of one of my job descriptions, okay? Not for appendicitis, not if they have a broken arm that needs surgical repair, obviously, but in general. And I've completely done a 180 with this, which is personally challenging to decide how hard to push, because I'm well aware, painfully aware of how huge the surgery is. But when I look at the patients as you're just describing, that middle group is the really challenging group. Okay, I know, and and most physicians know, the less comorbidity, the less concurrent illness, the better the strength, the less bedbound, the more their muscles work, the greater the likelihood they will have a good prognosis post-surgery and an improved recovery. Versus waiting until, all right, I give up, I'll do it, but by then they're half bedbound, et cetera, et cetera. So that's one group. And then the other group, as I said, are the bedbound patients. And I just was writing about this today. I've really kind of changed my approach on this. I am so convinced that if I have a new patient who's bedbound, they have CCI, and until I rule it out, that's what they have, CCI.
It's almost like until otherwise
proved, yeah. And
proven otherwise.
Whereas I used to approach those patients and say, all right, I'm going to go after the low-hanging fruit first and fix their mast cell and fix their infection and get their POTS under control, and then I'll pursue CCI. What I'm doing now is at the same time, in a kind of parallel track, immediately dive in on the low-hanging fruit, but I immediately figure out the logistics of how do we get MRI and how do
Yes.
we do traction, and can I get somebody to
Right.
come over and do physical therapy, because I'm pretty sure that's where they're headed.
I completely agree, actually, and that's what we learned at Mount Sinai with all these surgeries is that doing all of that other work, like the mast cell and the POTS, and the other dysautonomia disorders, and their gut, and all of those other
Yeah.
things that come along with the septat patient, we know that fixing that preoperatively gives them a better chance for recovery. But it, again, how you approach this is the perfect way to approach it, which is that also at the same time simultaneously start the process of how to get them towards traction. And so that is an important point that we should discuss, right? So
Right.
first we usually ask them, at least I do, I don't want to speak for you, but to do some manual traction at home if I think it's safe. There have been times that I don't think it's safe. I look at the MRIs. What's so interesting to me about the MRIs, which by the way we do a supine MRI. There are certain morphometrics. There's the clivo-axial angle. There's the Grab's measurement. There's the Harris measurement. We do the morphometrics. But what's interesting to me about these MRIs of the cervical spine is that there is probably almost all the time, close, loss of the lordosis, which, people have long attributed to muscular spasm, which I no longer think is the case. And also some other degenerative disc disease or, other spine pathology that you see on relatively young people. These patients are not old and have not been like master equestrians their whole lives, right? But yet, I see a lot of, what I refer to as bad spines, on these patients. And so you'll see a lot of cervical disc disease, even more distally than the C1, C2. And to me, those are signs that I need to look more proximal, right? Because something it's like the fulcrum of the whole spine, right? So it's, and I think that, the imaging is very important. So we do this imaging and then we have them do some manual traction at home, because one thing that we try to stress is that abnormal morphometrics are one thing, but clinical response to traction is an important thing. But also, I've seen patients have a remarkable clinical response to traction, but morphometrics are either normal or borderline.
Yeah, let me jump in on that, because it's really important. So I used to, when I first learned about this was all new to me. I don't know, 8 years ago, something like that. Paulo Bolognese, the neurosurgeon that we both work a lot with, the sequence was, all right, if you suspect something, get an MRI and then consider traction. And that has actually gone a full 180 as well. Or I at this point will definitely go down the traction road first. Because one of the things I've seen is how often that cervical MRI it's almost always normal in the routine radiology reports.
Yeah.
I don't think I've ever seen one that comes back. Occasionally, let's say maybe a Chiari-1, but other than that, he or you will see abnormalities. I don't trust my reads, so I give them to you or him. But regardless of the morphometrics, the money is in the traction, as far as I'm concerned. And it saves a lot of time, particularly in those bedbound patients, again, who getting a cervical MRI is kind of like climbing that Everest for them. So the traction is so powerfully revealing.
Absolutely.
And I agree with you. I prefer initially hands-on traction from somebody else, a PT or somebody, but sometimes that's very hard to do. And the home traction can be very revealing. The over-the-door traction, it just tells you so much. It's so low tech, but so revealing. It's incredible.
I think the home traction is actually more useful than manual traction, because one, with manual traction, you don't really know the poundage that's being applied. And then with home traction, what I like about it, for those that I believe it's safe, they can control it. And I have actually say that even though our instructions that we hand out sort of say, I forget it specifically, but like start at 10 pounds and do it for 10 minutes. I don't remember what it says, but I will just verbally tell patients, listen, you control it. If you want to start at 5 pounds for 2 minutes, that's perfectly fine. Whatever feels good to you. I explain to them our goal of this traction trial, and I explain to them the kind of information that I want to glean from it, so that they know where they're going. But how they get there is really up to them, because I want them to feel safe. And then, of course, where the real money is, and again, we're not referring to money for our pockets. We're just saying where the high yield is. Where the real money is when there is some positive response, and then we refer them for invasive cervical traction, otherwise referred to as ICT, of which Dr. Bolognese is actually the only neurosurgeon in the country right now that does the ICT. I mean, there are several that do the fusion surgeries, but he's the only one that at least currently does the ICT. And it really is a harbinger and this is what we have found at Mount Sinai when we look at all the data that he's compiled. It's a harbinger for who has a greater chance of having a good outcome.
Right. Well, that's
yeah,
precisely why he does it.
Right, exactly.
Which is what
exactly.
one of the things I admire so much about
Absolutely.
it.
And and he's able to sort of know who truly is a surgical candidate.
Right. He's basically trying to predict the future.
Right.
By showing that with ICT, all symptoms resolve, or 85%, and it gives him guidance into what to do. He's doing his imaging at the same time, so he knows where to put the hardware and how much to lift, etc.
Right.
And what I would say to any physicians watching or patients who are skeptical of this, just watch a few videos of ICT.
Yeah.
It is a blankety blank miracle.
It is really is. Yeah. And I've been in the room.
Trying to control my New York language.
I think we're allowed to curse on
all
podcasts.
Right, well, it's unfucking
This is people are paying for this. We can curse all we want. I have been in the room during ICT, and like it almost brings tears to my eyes, you know?
It does bring tears to my eyes.
I will tell you that patients, their faces change. And what I don't think we talk enough about in medicine, and maybe this is another topic, is that what chronic illness does to a patient in terms of like not only their affect, which I think to some extent that's obvious and instinctual, that it would change like how the person's personality when you're suffering and your whole life is upended because you can't do much. But it changes how they look. And as doctors, and we just, of course, first meet them when they've been suffering and usually suffering for a very long time, as you know. When it changes how they look, I have seen patients' faces change just by him, you know, he uses the halo, and so this is a very objective kind of methodical traction, right? And he does it incrementally, and at every increment, he takes pictures so he can do the measurements, and then he asks clinically, he'll list 3 or 5 symptoms.
Yep.
How are those symptoms? Are they better, worse? And you can see just like light in eyes.
It's unbelievable.
It's
incredible. It makes me think you and I should explore whether we can get somehow permission to post some of these videos, get patient permission.
That's a great
Because
idea.
again, I'm aware of all the skepticism, and I'm aware of why do you want me to do surgery? I go online and I read about all these trauma and complications, and I'm not doing it. They only read about the bad stuff.
Yeah.
Okay. You just see a few of these videos. It's what you just said, and I'll add some more. I've seen patients say during and after ICT, I didn't know I had trouble with my vision.
Mm-hmm.
All of a sudden I can see.
Exactly.
I just had a youngish woman. She said, wow, I suddenly can actually read the letters completely differently.
Mm-hmm.
Or I didn't realize I had a hearing problem. And then when their head is tractioned up, it's gone.
It's amazing, actually. They can read.
Amazing.
They'll say that in terms of their thinking, they didn't think they can think so clearly. Their mental clarity is improved. You know, so it's not only like clearly objective symptoms like headache or weakness of an arm, but you're right. The way they see, the way they think, they didn't even appreciate how that had been affected by their CCI.
Right.
And so that traction is so important. And the other important point to make about the ICT is that it simulates the fusion, right? So he finds, that's why he asks all those questions with regards to how are your symptoms, better, worse, and he asks people to give a rating of percentage-wise, which I think some patients have complained about because, you know, they have a hard time estimating.
Subjective.
Is it 70%? Is it 80%? But it's important to him because, you know, if it's not a resounding 80% of improvement, like then he's worried that maybe this isn't the right spot, or that maybe you're not yet ready for fusion. So he tries to find that sweet spot, as I call it, where he would simulate the fusion, which it's not always exact, of course, but that's a good spot where at least they showed a remarkable clinical improvement. And and also the morphometric changes. And so, you know, when he sees changes of the measurements as well, we have had lots of patients who have had, you know, significant changes in their measurements, but not a significant enough clinical improvement.
And vice versa.
Yeah. And in those cases, he usually says, we'll repeat it in 3 to 6 months kind of thing.
Right. And he's another piece to understand in terms of ICT is that it is basically preoperative planning.
Right.
Okay. So it's not just that the symptoms get better. So, okay, we should fix you. It's how should we fix you? How much should we fix you?
Exactly.
It's like you do in cancer medicine, you'll do not pre-op, but chemo or radiation planning, so you know exactly where to put stuff and beam stuff, and it's a critical part of it. So he knows in advance.
Yeah. No, I agreeing basically. Critical is the best word. I mean, I wouldn't do a surgery without it, and I think it just shows so much information about the patient's CCI, their anatomy, and their response of what we can expect from fusing them. And that's how it should be done, frankly. I think that's the way it should be done. And now we're actually doing even more of a preoperative workup. In fact, during the ICT, we've added flexion and extension, so it's a little bit more extensive and comprehensive. And also the imaging, we're now thinking more about the venous circulation and how that's playing a role, because of course many patients come with symptoms that can be about their intracranial pressure, and oftentimes there's a mixed picture. And I often explain that because of the CCI and the compression of all of the anatomy within that joint, you can have elevated pressure in the skull and low pressure in the spine, vice versa. Or some days you have full elevated pressure, some days you have full hypotension. And so he does the ICP bolts usually during the ICT, so he can get a good reading of the pressure, and he measures it all around, and he does it for 48 hours and sometimes longer. And so, we get really great understanding of the physiology of their cerebral circulations, right? So, and occasionally we add the transcranial Doppler so we can see arterial flow. And then we do venograms. And so we sort of see, is there a compromise of the outflow, right, of the venous outflow, which is often, of course, at the IJV in the internal jugular vein. But, don't forget, these patients have had such chronic problems for so long that a lot of venous collaterals form. And that's important to know as we go into surgery, right? Because you sometimes have to cut the collaterals.
Right. So,
and that can be something that we need to be aware of, and to sort of be either proactive about it, or, somewhat, after the surgery, we can at least assess what we need to assess, knowing what we know about this particular patient.
Right.
It's all very individualized, right? So this is not like, a textbook surgery, although it's not in textbooks, actually. So technically it's not yet textbook surgery, but we really do try to personalize it and individualize it to each and every patient.
So let me take the individualization a step further. And,
okay.
In one of the earlier episodes when we talked about septad, one of the themes that we kept coming back to is that everything interacts with everything else. We're not just saying you have POTS one day and MCAS another day. They all affect each other, okay? Similarly, patients with CCI who are headed towards surgery because of their exam and clinical history, and then ICT and the bolt, many of those patients have way more than just CCI.
Mm-hmm.
And again, it brings back to how you described this incredibly complex joint, and the brainstem and the cranial nerves and the internal jugular veins and compression and everything else. And I think that's a key thing to try to convey to patients, and maybe we need to even do another episode about this, because one of the things I hear is, well, somebody had CCI, a fusion, and they still have problems.
Mm-hmm.
Well, yes, the fusion fixed one part of a global problem, and people need to understand that. And and I know, I would say almost every single patient I've sent for fusion has ended up also having a tethered cord, which we'll get to, and almost or frequently has venous compression syndromes and stuff like that. So it isn't just one problem, and you can't therefore judge the surgery that way.
That is very true. So, right. So yes, in that area, there's a lot of important anatomy. And, even speaking about the C1, sometimes it's because of the instability, sometimes it's turned in a certain way where the tubercle is sort of compressing the IJV.
Right.
So there's lots of things that we need to look at. And we do, like I said, the imaging now that we do preoperatively for the CCI is much more extensive than it used to be. And we even look for a tethered cord at the same time, because it's important going into surgery to sort of know what coexists. And they very often, more so than I would have expected, to be honest, coexist, right? So there's often a CCI picture, a tethered cord picture, and even like an Eagle syndrome picture. To the severity of each can be different, but to some extent, they all three often coexist,
exactly.
Right? So it's important heading into surgery to sort of know that. And then, recently the conversation has been with patients about, well, what should I fix first? And I used to think, I think fixing the CCI was important because it's sort of, I feel like it houses everything else, and it sort of, directs everything else. But, because that surgery considered to be a lot more intense. It's got hardware involved, and none of the other surgeries do. That I think that some patients are preferring to do the SFT, for example, for the tethered cord section filum terminale, or even either a styloidectomy or a resection of the C1 tubercle. And I think because those surgeries just sort of seem a lot more simple to them, and they want to see how their symptoms resolve if they do after a different surgery. And I think that's fair. One thing that I always explain is that sometimes doing the CCI can make the tethered cord worse, and vice versa. Sometimes correcting the tethered cord can sometimes flare the CCI symptoms where it becomes very problematic.
Right. No, I've definitely seen that.
Yeah.
And it seems to vary. I mean, Dr. Bolognese never, at least initially in my initial series of patients with him, would always go for CCI first before tethered cord. Now I see him sometimes doing tethered cord first. Partly it's just a relatively easy surgery, and maybe it will help. I mean, if you just think about it crudely, if you have a tethered cord and you release the tether, that may release some pressure on the base of the brain and make it a little better. I don't know, but you need to look at all these things. That's the bottom line.
Right.
And I tell every patient who I send to him for fusion, expect that you probably have tethered cord, and that will come up next.
Right. And it usually does.
It does.
And a lot of patients have had subsequent surgeries for sure. And I do think, this is all theoretical, of course. We don't really understand enough. And I hope that in the coming years that we get to do a lot more research and really learn more about this. But I do think that you're right. So if there's tension on both ends, you release one part of the tension, maybe it sort of loosens this up a little bit. But the problem is it's already unstable.
Exactly.
Right. So I very often see, and again, this is my own experience. It's anecdotal. I have no idea if this holds true scientifically, but I often see the CCI get worse if people choose the SFT first. I don't always see it. There are exceptions to what I just said, but and I think it's because the tension might just sort of keep things in place a little bit more. So there isn't as much compression.
Point. That's a very good point.
And so you release it and now it's just, all over the place. But
But
I think we just need more research to understand it.
Let me ask you a question in your experience referring to patients before they end up in the OR with Dr. Bolognese. Have you seen any patients who you were clinically sure based on traction imaging history, had CCI that needed fusion, in your opinion, get any clear benefit from the other alternative approaches, which are basically, injections and things?
I have seen benefit, but they are short-lived.
Right. So they still end up needing surgery.
They still end up needing
That's
surgery.
my experience too.
And the other problem with some of those injections is that these are mast cell patients. And I have a whole host of patients that every time they go for injections, I have to, manage their mast cells.
Right.
And so to me, it's almost like, taking 2 steps forward and 3 steps back, right? Because now you've provoked a mast cell reaction, and that's just more inflammation, more degradation.
For me, a difficult situation to be in with patients who say, I want to go try this, because I don't think it's going to help. And they're going to spend tens of thousands of dollars. It's not covered most of the time.
I agree.
And at the end of the day, I don't think it'll help because this is a neuroanatomical problem. But I also don't want to sound like I'm pushing surgery so hard and discouraging them. But at the end of the day, I don't see how it will help. I have this very, very crude image I use with patients where I say, okay, you can try it, but just hear this out for a second. If you're driving your car and you have a flat tire, you cannot fix that tire unless you jack up the car. And all of those injections will not jack your head up off your neck.
I like that. Can I borrow that?
You may borrow it. It's very crude, but you can borrow it.
A flat tire. I like that a lot. But it is true, right?
Yeah.
And I think that, I'm sure as well as you, I'm often asked about these injection therapies. And it is what I say. I say that there's no doubt that some patients say that they feel better after the injections, but every single one of them, eventually the symptoms return, flare. A lot of them, as I've already said, have mast cell reactions to the either the prolotherapy, the dextrose solution, or even the PRP. And so I think that if they want, I don't say absolutely not, you can't do it. Of course, I believe in patient autonomy.
Exactly.
People can do what they want, but you're right, it's expensive, and in the end, it's not going to solve the problem. And then you might end up being worse a few years later, and then the surgery is a little bit more complicated, and so. So I think, and that's what we were talking about earlier in the session, which in the podcast, which is, when do you go to surgery? When is the optimal time? And, for my young patients who are still functional, I say you're a good surgical candidate right now. There are no operative concerns for you. And I think you have a good chance at a good recovery. So, I don't force them, but I strongly recommend it kind of.
So I want to circle back a little bit to something else we said in the beginning. I think we're nearing the end of this. I think we are in agreement regarding patients who need fusion surgery. Okay. And we're in agreement that we'd love to avoid surgery. The question and challenge is, how do we identify those patients who are at risk for surgery in the future unless something is done?
Yeah.
And I believe at this point that there's three groups of patients. There's the patients with connective tissue disorder, hypermobility EDS, but I prefer the broader term. There's patients without that connective tissue disorder who have chronic inflammatory illness, mast cell activation, small intestine bacterial overgrowth with leaky gut, POTS, chronic infection, tick-borne infection, etc. Mm-hmm. And then there's patients who have both. Okay. And I'm almost at the point, this is now going out on a limb. If I have a patient with POTS, mast cell activation, a septad patient, what's the 6 number? Six-tad. A 6-tad patient.
Oh my God.
If I have a 6-tad patient, I'm going to, this is not the limb, assume that patient's going to end up needing surgery if I don't do something now, not only to fix the 6 parts of the 6-tad, but aggressively do things to try to strengthen their connective tissue. And I don't have the answer to that. I mean, that's another podcast, I think.
Right. Well, I would love to have a discussion with you about that. And I've said many a times, the holy grail question is, how do we fix your connective tissue?
Right.
And none of us know that. I mean, obviously, we have tried different things. And I think that we've actually seen some improvements with, some of the regenerative work that we do.
Yes.
I do believe that patients are responding to peptide therapies and stem cell therapies and so on. So I think the answer is there. We don't know it yet, but I would like to believe that we're getting ideas about how to help their connective tissue, because that will help them. And especially when we catch these patients early on.
That's what I'm talking about.
Yeah, no, absolutely. And so I think that is the key for them. And, you and I are both willing to think outside the box, obviously in a very safe. I always say that as rogue as I am, I'm very conservative in my rogueness.
Right.
And so I think for, properly identified patients, I think, we're both willing to try things that are not necessarily conventional, just to try to help with improvements of their symptoms and try to avoid, and actually ultimately avoid surgery. Wouldn't that be nice?
Right.
But
well, I think that's my biggest responsibility, actually, would be to not send them to Paulo Bolognese, but
right. Sorry, Paulo.
Well, I love him, but
I know we both love you.
He's a surgeon. But figure out ways to prevent that. The problem is deciding who gets that treatment. I believe what I just said to you.
Yeah.
And 2, what those treatments are. And the problem we have is that most of those treatments are totally outside the box.
Yeah.
Often FDA not approved, often experimental, never reimbursed by insurance. So now I take a patient who isn't feeling too bad and doesn't yet have a collapsed head on their neck.
Right.
And I'm saying, all right, well, I want you to spend $15,000 on these different things to strengthen your connective tissue, and I don't have a clinical trial to prove that.
And I also can't guarantee it'll improve.
That's what I mean by the trial. So it's a very uncomfortable position.
Yeah.
But I actually think that's where we need to be going.
I know. And I would love that. First of all, we can have a whole podcast on treatment, things that you and I have both done, because that's an exciting topic. And then we could, and then I would love to talk about trying to get money to do these trials.
Yeah, yes.
Anyway, I think that's our time. Our time is up for this particular topic, which I'm sure we will revisit over and over again, because there's so much to say. But thank you for joining us.
Thank you.
As always, please send any questions, topic suggestions to our email address, unravelingcomplexillness@gmail.com. Unraveling is still with 2 L's. So
yeah, but please do send. I mean, also in the Patreon, if you're on Patreon, comments are helpful. And questions, and we are reading them, and
yes,
hopefully in the future we'll do some Ask Me Anything type episodes.
Oh, we definitely will, which is why we want you to send us questions.
Right,
and you're right, on the Patreon page, you can put questions there in the message section, which might be easier than the email.
Okay.
Yeah, great.
Thank you.
Thanks for joining us.